So I'll be talking on a topic we've titled Innovative Solutions for Sepsis Diagnosis and Treatment and Leveraging the Potential of BioFire Technology. That's what it looks like. So I just wanted really to say that yesterday, I think the presenters yesterday, they really helped us to set the scene for this talk, because Bridget was talking about the lab, you know, basically the BSI pathway within the lab, the blood culture pathway, how to improve that within the lab, pre-analytical, analytical, and post-analytical. So our talk today will be focusing mainly on outside of the lab, you know, what we do within our trust. So I'll be sharing that with the team today. So also just to note that although I'm the presenter, I collaborated with a number of amazing colleagues on this project, and I would like to mention them. So I was the project manager, and I worked with our sepsis lead nurse, Claire, and our microbiology consultant and clinical lead, Shabna, who is here with me today to support me with this. Andy, who is our trust AMS lead, antimicrobial stewardship lead, also a consultant, ICU consultant, and Manish, who is our trust sepsis lead and ED consultant. So in terms of the content of the presentation, would again just talk about the blood culture pathway, but I won't focus too much on that because we looked at that yesterday, I think. But I will just be focusing on the critical control points where we can make the gains, if that makes sense. And then what were the challenges we're actually facing within the trust, Royal Berkshire Hospital, and what was the proposed solution, and then the pilot of the proposed solution, what was our findings and the impacts that it had clinically on our patients. And also we have a couple of success stories to share with you. And then I will summarize and conclude, and then we can take questions. So in terms of the blood culture pathway, as I mentioned, I won't talk too much about it, but basically we've talked about the blood culture collection, and then we send that to the lab to be loaded on the incubator or analyzers. And then if it's flags positive, then we send to the main lab. And then we have the gram stain, which is the smear test, and then which requires a trained biomedical scientist. And then we do the culture to get the direct ID. And then within 24 to 48 hours, we get the direct sensitivity as well. So that's the normal laboratory blood culture pathway. I think it's worth mentioning that at RBFT, with the formation of Pathology Network, we are a spoke site. So we operate a hub and spoke site. So we are a spoke site. Any blood test or any diagnostic test that requires greater than 4 hours, we send to the hub, which is in Wexham. That's our Berkshire hub, because we are in Reading. So that means, you know, our microbiology lab is in Wexham. It's not on site. So I think our situation is particularly unique in that respect. We're a spoke site. So I'll talk about the challenges based on the fact that we're a spoke site and some of the things we are seeing. So as we all know, the UKHSA standards in terms of when to get the result back within 24 to 48 hours, we should have an ID for the pathogen. But our lab, as I mentioned, is off-site. So our turnaround time is between 1 to 5 days, but mostly tending towards the 5 days than towards the 1 day, if you see what I mean. So, and some of the complications of that is because of the transport. I think that was mentioned again yesterday. You know, we have just very few transports in between the spoke site and the hub lab. And then, you know, sometimes things also the other thing to mention is the service hours for the main lab. They're only open between 7 a.m. and 5 p.m. Monday to Friday, and then 7 to 3 p.m. Saturday and Sunday. So it doesn't operate 24/7 as well. So there are a number of limitations in terms of using the lab, the main lab for the test. I've mentioned the lab is off-site. And of course, as we've seen yesterday and also today, if you have BCI and it's not diagnosed on time or not treated on time, then it's not good for the patient, because then it increases the rates of mortality, basically. This says that the risk of death increases 1.2-fold for each day of delay in microbiology diagnosis. So what are the challenges? Of course, then, because if you don't diagnose on time, you don't treat your patient on time, or you just put them on the empirical antibiotics that doesn't really work for what they've got, so there's tendency they're going to stay in the hospital for longer. So, and then they're taking up the bed for other patients, and then that impacts the flow and discharges as well. And it's not good for them as well when they don't need to be in the hospital or when they need to go back home on time. So we also have limited side rooms. So if we have patients that, we don't know what infection they've got, CP or something, we need to isolate them. And we have very, very few side rooms. So we've got that limitation as well. And of course, the more they are in the hospital, the more they will need requirement or escalation to level 2 or level 3 care in ICU. Also, we've talked about AMR yesterday, antimicrobial resistance and the need for antimicrobial stewardship. Again, if we just give them antibiotics they don't need, it's not good for anybody, not good for the environment as well, as we have seen yesterday. And not just that, the associated side effects. I think Andrew mentioned that broadly yesterday and explained that. So again, that's poor patient experience. As we know, sometimes patients come into the hospital, they actually live with other forms of infection. So really, we really don't want patients in the hospital if we don't need to keep them in the hospital. So if they come in, we treat them, and then they go back to where they consider their home, maybe care home or their home, and then that's better outcome and better experience for our patient. So those are the challenges we're facing. So again, everybody knew about these challenges. It's not new to anybody in this hall. But the problem, I think, like David mentioned, is the adoption of technology to help us actually resolve those issues. And of course, one of the issues is funding and all of that. But I want to share with us what we did and how we're able to overcome those challenges. So we proposed the use of BioFire technology. So if you remember, we're on a spoke site. So we're able to put that within the business case. A 24/7 service, regardless of when the patient comes, we'll be able to actually test the blood culture and get an ID within 65 minutes, compared to maybe 72 hours or that you get in the lab. Or I think the average from Bridget's study yesterday was about 58 hours, if we're being conservative. So that the proposal is for the technology or the machine or the analyzer to be hosted by the Blood Sciences Rapid Response Lab, because then we have trained technicians, so there will be a quality assured service as well. And then I think, like David was mentioning, and some people yesterday as well, you don't just use the technology, you need to make sure the governance is there, so that for patient safety purposes, the results are trusted. So, and we've got biomedical scientists within the Blood Sciences Lab. So if they look after this in collaboration with our microbiologist and the microbiology lab at the Wexham site, then we'll be able to have quality assured results. So I put forward the business case with inputs from the clinical leads and those people I've talked about previously. And we took it to our CEO. And because it's an expensive test, so you're looking at, per patient, the BCID2 panel, when we costed it, including the running cost, everything came up to about £120 per patient. So compared to the lab where you've got economies of scale, it's not even comparable when you're looking at just one test. But then when you look at the hospitalization cost, the reduction in the length of stay and all of that, then you could see the benefits, of using BioFire to quickly help your patients and also discharge them and free up the beds for other patients that need the bed. I think yesterday it was so amazing for me looking at Dr. Jane Freeman's data on the hospitalization cost and the ITU cost, because we use a reserved and very conservative costing for our business case. But yesterday she was showing about 800 and something for ITU cost, hospitalization almost £3,000, so it was about 2,600 and something. So we use very, very modest and conservative figures for our business case, and I think rightly so. So we just wanted the exec, our trust exec, to give us the go-ahead so that we can pilot it. Initially, we asked for substantive. They're like, no, pilot it, let's see, the benefits, and then we can then take it to business as usual if it shows, improved clinical outcome for our patient. So we asked for a pilot of 3 months, and the exec actually said, no, let's extend it to 6 months, because then it's better, we'll be able to see, demonstrate better the evidence of having that technology. So pre the pilot, we had to agree, because they were giving us money for this, so we had to agree what the KPIs are, for the pilot, even before we started. So the key thing is to compare the BioFire, which is the technology, the picture there, with the conventional laboratory Morditov method. And then we review the impact, of going through that process on our patient pathway. And then we determine whether we decided the clinical scientists alongside the medical colleagues and ourselves, we decided on 3 key metrics that we needed to measure. And that's number 1, reduction in time to ID pathogen. So basically improving the process and the turnaround time for the results. Then reduction in time to effective therapy. So when you get that result, you can get the result, but doctors are not acting on it or something. So we needed to check that when we do have that result, it's actually improving. Are we changing antibiotics? Are we, and all of that, the impact of that. And then lastly, this is the funding element of it. We were saying to them, we're good stewardship of the money you are giving us. We want to make sure we use the blood culture, the BioFire, when we need to, so that, we want to reduce contamination. And then we set ourselves a very high target of less than 3%, so that we reduce the wastage and only use the BioFire on good samples so that then we can get results which we can rely on. So what are the pilot findings? So the pilot was carried out between January and June 2022, last year. So during the pilot, there were some challenges, but during the pilot, we processed 183 patients using that new process. And the majority, of course, are from ED. So patients coming through ED. Also, we have ICU. I know we have ICU colleagues here, and then, of course, AMU. And then some other people on the, other patients on the wards. So the first thing we noticed was the sample collection that we measured was sample collection to pathogen ID. The BioFire, which was on site, we received our results within 4 hours. Whereas centralized lab off-site, we received the results, less than 27 hours. So on average, when we looked at all 183 patients, the time to pathogen ID we saved 17 hours per patient, using the BioFire technology. So I included this graph because, as you know, when we started the BioFire pilot, we wanted to make sure we have IT interface, but there were lots of issues. So we thought, let's just do it without having automatic data transfer, and then we can work on automatic data transfer later. So when we started, we would get the result from the analyzer and then manually transcribe those results onto the system. And as the lab staff got more used to the process, you could see the time. So that's the one in blue. The one in blue at the bottom, that's the BioFire one. The time, got reduced, especially in May, because then we had the staff in place, and then we had a better way of getting the result onto the system. So basically, we just scan the result and put it on the system rather than manually writing each of the tests onto the APR. So if you compare that to the lab, the time is just, I think it speaks for itself. So then the other thing we looked at was, of course, we have this technology. We had to carry out verification and compare it with Morditov, which is the trusted central lab method. What is the agreement between those methods? And we realized that it has 75.6 degrees, percentage in terms of agreement, which is really, really good. That's a very high agreement, between the two methods. But 8 were not in agreement. So we dig deeper to see, what happened to those 8? Why were they not in agreement? 4 of those 8 are non-panel, so they are not on the BCID panel. The BCID panel has about 43 targets, including the resistant genetic markers. So, but 4 out of those were non-panel, so there is no way you could detect it anyway. And then 2 were actually false lab result. So the result the lab gave was not the correct one. The one that BioFire gave was correct. And then because we had a repeat, and then lab was actually the wrong result. And then we had 2 false negative with the BioFire, result. So, so I've just added that table. I'm happy for the presentation to be shared so that you can see the details. That's just the summary of all of those things. One of the things we thought is when we looked at it too, we thought because they are false negative anyway, we're going to chase more Morditov result anyway, because throughout the pilots we're doing both. And then we thought it was a risk that was acceptable in terms of the agreement. So we're quite happy with that. Then, so how did that translate to use of antibiotics? We noticed that about 68% of our patients were impacted as a result of that early receipt of results or ID of the pathogen. 31% remain unchanged. So when they came in, we put them on empirical antibiotics. We didn't change them. So I've just included a pie chart of, for those 68% that were impacted, the 125, how many were changed, how many, did we start antibiotics on? That one was really good because we actually started, those results came back so early that we were able to actually start the antibiotics without giving them the empirical antibiotics. So we gave them the targeted antibiotics to start with. That's where we want to get to. With the interface, that would make it possible for us. That means we can get the result within 70 minutes or let's say, less than 2 hours, and then we'll be able to start people on the right antibiotics. And then there were some that were actually de-escalated. I remember this was talked about yesterday as well. They didn't need that, antibiotics. Let's just give them something a bit narrower. And then we escalated some as well. And we stopped some, which is really, really good as well, and saved us money in terms of antibiotics, saved the environment, saved the patient, and all of that. So sources of, this is another thing as well, that in terms of source control, because we're able to get the results on time, our microbiologists could actually advise the medical team, on the source control, what to do. So if you get E. coli, what is the source? Is it biliary? Is it the kidney? And all of that. And then do we need a urologist? So there was a lot of work that was done in this. What we found though was the top 3 in terms of sources of infection: urinary, biliary, skin, and soft tissue. And again, this mirrors, I think, the figures or the data that was presented by the Sepsis UK Trust yesterday as well, in terms of the sources of infection. Also, because we're able to get those results on time with the improved process, we're able to carry out promptly 49 interventions for our patients, which was really, really important. So those, again, are the type of interventions that we carried out. So what is the impact of that on the duration, the length of stay, and the duration that patients were on antibiotics for? So what we realized was the trend when we looked at the data, length of stay actually follows the duration on antibiotics. So patients are, they spend, if they are on 1 day less on antibiotics, it reduces their length of stay by 2 days, which is just so amazing. That means they go home 2 days quicker than they would have. They don't have to, have those antibiotics when they don't need to. So there is a lot, and we've just talked about hospitalization costs, cost to ICU, and all of that. Some of our patients were escalated to level 2 or 3, but it's 14.8% of those patients, they were escalated. So it will be interesting to see, Bridget or other people, how many of your patients get escalated to level 2 or 3 care. But we do know, compared to when we don't have the BioFire technology, this is really a good thing. Again, we just included that just to see the trend in terms of the 1 to 2 trend. 1 day less on antibiotics, 2 day reduction in length of stay. So the impact on patient outcome. Unfortunately, some of our patients passed away due to bacteremia. 31 passed away, mortality rate of 16.9. I know there were a lot of mortality rates that we talked about yesterday. There were some figures, 20% being thrown around and all of that. Of course, we want all our patients to, to leave the hospital healthy and all of that, but we think this is, in terms of mortality rates, it's not as bad as we would have if we didn't have the results on time. And again, I think I was listening to, was it David earlier, talking about undiagnosed BSI, there is a risk of 30-day mortality, mortality risk of 50%, I think. So, so again, we're able to discharge 120, so that's 66, about 67% of our patients were discharged. So out of those that were discharged, we went further. We wanted to see, did we readmit them due to infection? Because then maybe we just send them for our figures and then we actually brought them back in. So we look at patients that were discharged, and if they were readmitted within 30 days of their discharge. So out of the 120 that was discharged, which is 67% of the total, 18 were readmitted within 30 days. So that's 15%. But out of those 18, only 7, I mean, I don't want to use only, but for the purpose of this talk, 7 were readmitted due to infection, so which was followed up. And then again, that's just the graph basically saying the same thing. So remember the 3 primary metrics that we established before we started the data, the pilot. If those 3 measures were not met, the trust is like they are not going to fund it into BAU, into business as usual. So we had to demonstrate that we're able to meet those measures. So how did we do? Reduction in time to identify pathogen compared to routine care, compared to the main lab. Of course, we were able to achieve that. And we saved 17 hours per patient on average. More for some patients, but on average, 17 hours per patient, compared to sending to the main laboratory, which is off-site, which has limited service hours, and which has other limitations in terms of transport. So did we have improved management and outcome? Again, yes. Patients were on targeted treatment within 13 hours. Again, this improved significantly to approximately 3 hours for April and May, as the BioFire process became embedded within blood sciences lab. I think something to mention there is the blood sciences lab are no microbiologists. So, and that's the amazing thing about the BioFire technology. You don't need a microbiologist to run it. It's like a point of care test. So, but it took them a while to get embedded within, with the new analyzer. They're like, oh, that's microbiology. No, anybody can do it really. And then we had to train them. So 3 hours, you could start a patient on targeted antibiotics, April and May. And we know that is definitely going to improve once we have automatic data transfer. And then the money, which is the finance manager was quite mindful of that. Did we reduce the contamination rates? We didn't meet the less than 3%. I think we were too ambitious, but it was good. It was an ambitious target. But what we did do was, because we are part of a network, we looked at the other hospital sites within our network, and we're actually doing very well compared to the other hospital sites within the network. So the data is there. So we met, and when we looked at each of the months as well, just to see why, sometimes we didn't have staff, sometimes we had staff because it was a slow start because of funding. But generally, I think our overall median was 3.4 and mean of 3.6. And for the other BSPS sites, it was greater than 4. So, which was really, really good. So our CEO and our execs, they were happy with that. But we didn't just stop there. So what we are doing is we still want to achieve the less than 3%, you see? And we thought, what can we do to improve that? So the main thing is this device, the one at the top, is a curing device, K-U-R-I-N. So we are currently piloting that device. So when the blood is taken, the first set of the sample will be absorbed within resin, within the blood collection device, within that device, and then only the second set will go through into the bottle. So that means you kind of eliminate contamination as much as possible. So using that device, we're currently piloting it, and it's going to be on for about 3 months just to see how that improves the contamination rate. In addition to that, we also did education and training. Our sepsis lead nurse, Claire, led on that with the doctors. And again, we are seeing improvements already in terms of the contamination rate. So we would just want to share 3 success stories so that we could see how this actually impacts. We are really excited about this, how it's impacted our patients' lives. So I'll just display that and talk briefly about it. So we had a 44-year-old male, was brought in by the ambulance in ED, had severe sepsis, was unwell for 3 weeks prior, history, sore throat, cellulitis, swollen elbow. Based on our sepsis 6, 2 sets of blood cultures were taken, sent to the lab, started on empirical antibiotics. And then when the result came back, BioFire on site. BioFire identified group A strep, and then targeted antibiotics was started within 10 hours of admission, which is a significant improvement if we're waiting for the people in the lab, especially if the sample has come between 5 and 7 a.m. the following day, or if it has come during the weekend between 3 and 7 a.m. there was nothing we could have done, even if it's, flags within the incubator. So the other thing, as we know, in terms of Group A strep, we quickly notified UKHSA as well to do contract tracing. So they traced the close family and started them on prophylaxis, prophylactic antibiotics. And then patients became clinically stable in ICU. So it wasn't just for the patient, but also to protect their loved ones and everybody else around them. So this was a very, really good example. We've given, the hours there in terms of comparison between BioFire ID and ModTof ID. Okay, the other one, success story we have is the VRE case. Again, 58-year-old male with leukemia, fever, and neutrophils of 0. We collected blood and then loaded it on the blood culture incubator or analyzer. Sample flagged positive, and the BioFire confirmed the organism, and our microbiologist again advised on the antibiotics to use. Antibiotic was changed. Sources of infection was identified as well, and targeted. But if you look at the time that the conventional lab ID became available, it wasn't available until like few days afterwards. So this is really, really good. And then I think the last case we've got, a meningitis case, and this is a 2-month-old baby. So it was admitted to Dolphin Ward, that's our children ward, via PITS ED, presenting with fever, diarrhea, and then, of course, we took CSF sample. So we've never used the BioFire for CSF before, for fluid, as part of the pilot, but we do know it has the potential. And we'll be doing some work in the background because we are looking at perhaps using it later for that. So we just, our microbiologist, Shabna, our consultant microbiologist, said, can you please process this on the BioFire? Just so that, because the baby was really sick, the mother was worried, rightly so. And then we processed it on BioFire while still going through the lab, the central lab of everything else. Immediately we're able to realize that actually, it's enterovirus using the ME panel, which we now have on another ward. And then, so all antimicrobials will stop. There was no reason to give that patient antibacterial when the patient, antimicrobial when the patient doesn't have, only has a virus, if you see what I mean. So all antimicrobials will stop. And the Hampshire patients were reassured to say it's viral. Unfortunately for William, it was the other way around because they thought it was viral. So that's the patient, Melissa, that shared the story yesterday. Very touching story. She kept going to the GP. They said viral, but actually it's not viral. On this occasion, it's viral. So they stopped the antimicrobials, and the patient, the baby and the mother and the parents, they were discharged home. So in summary, we are very, with evidence, we are very clear that the BioFire technology has transformed diagnosis and management of sepsis at RBFT. And pre-analytical, we're able, all our blood, in terms of blood collection and everything, we got into the incubators within the 4-hour standard. We work with the clinical team to achieve that. We're doing training with our doctors so that when they are collecting samples, they collect it in such a way that the sample is actually of good integrity and doesn't have contamination. We are piloting curing at the moment, and then hopefully get funding to roll that out if it works, if it improves things. And then the analytical, as we've seen, we saved significant amount of time, minimum of 17 hours. There were some that, much more than that. And post-analytical, again, we put that in amber because we've not implemented the automatic data transfer. So once we have that, things will even be quicker. So as we've seen, early pathogen ID facilitates early multidisciplinary team conversation around therapy, source control, investigation and interventions, and then the infection and prevention team and the AMS team in terms of bed management, tracing, and isolation of patients. Isolation in side room and using our side room, our limited resource appropriately. Then, of course, confidence to ambulate virtual ward, which is one of the things that we are now focusing on again in the trust, using BioFire again, so that when patients come through ED, and we've used Sepsis 6 taken two sets of blood cultures. We sent them to and started them on empirical antibiotics, put them in AMU. We really don't want to send them to elderly care ward or any other ward from AMU. So because we can get the result and carry out effective, targeted treatment within 6 to 8 hours. So within AMU, they will stay there, and then from there, go back out either to the care home or to their home. Of course, it's multidisciplinary. Our microbiologists are working very collaboratively with the acute medical doctors to see, to provide supported discharge if necessary and all of that. And then when the patient is discharged home, the virtual team would call them twice a day or once a day, depending, to ask how they are. And then they check, their vital organs, vital signs, bring some back in if they need to. But in terms of the work that we've done so far in the virtual clinic, which started October last year, we've really brought patients back in. So that is the amazing thing of just getting your result there and saving the patient from going to elderly care, where we know that once they go there, they tend to deteriorate rather than get better. So what are our next steps for us at RBFT? I wrote down the report. We presented all our execs were interested. We presented the report at our various care group or divisional care group board. And then we also took it to our execs board, and then they approved it and they provided us funding. So now it's business as usual for us at RBFT, and that is saving our patients' lives. We can't begin to explain that to you. It's improving, patient flow and discharges at RBFT. And of course, we need to implement the automatic data transfer. That's the next project that we need to work on. And the other thing as well, if you remember, I mentioned something about ME, the meningitis panel. We have that on one of the wards at the moment, and we also have the pneumonia panels, being used on one of the wards at the point of care. But we want to bring all of that into the main lab as well, into the blood sciences lab, where you have the technical staff. We already have the infrastructure there. We have the staffing 24/7. Then it will give the clinical lead the time to actually focus on the patient whilst we do the testing. And also, as we know, in terms of point of care testing, they don't do the cleaning, they don't do all of the usual things that they are meant to do. So it's better in the lab anyway. But as long as they can get the result on time. And also, we can provide due diligence, make sure in terms of the stock control, making sure we're using the resources effectively. So better governance, oversight, and transparency for all care groups. That is important because all the care groups, these are divisional groups, they contributed to the BAU funding. So as a DM, I call we have 2 weekly meetings with our clinicians, with the labs team and all of that, basically to explain the budget, the pay, the non-pay, the reagents, how much stock we've got, what is on order, the Datix incident, we're learning from that. Do we need to train? So there is a lot we're doing every 2 weeks. We have that meeting for now. And then we are hoping that over time, we would reduce that to once a month in terms of the meeting. But that is really good. And it's so good to see that we're actually meeting all our target in terms of the pay, the non-pay. It's just so good to see. So where do we want to be? What we want as RBFT staff and all of my colleagues that are not here that I'm presenting on their behalf, what we want is, we want to be able to say if I or a loved one had sepsis, they will want to come to RBH. So I will just quickly share a personal story with you. My brother was suspected of having sepsis. So I live in Swindon. So we took him to Great Western Hospital. And remember, I have implemented, with the help of my team, BioFire, so you could get the result within 2 hours. And then we were at Great Western. One, they were not even thinking sepsis, so they think sepsis thing is important. Anyway, long story short, I was like, if this was our RBFT, we could have had the result in 2 hours. Should we just take the blood bottles and send it off to my hospital so that we can get the result? But it's funny because when it happens to you, then like the patient voice yesterday, but we shouldn't wait till it happens to us. We should do it anyway, knowing that there is a life at the end of it. There is a patient. That could be my relative. That could be somebody else. So it was just quite good to see. And I would just like to conclude that we did that based on our trust care values, being compassionate, being aspirational. we're early adopters of that technology. That technology has been around for a long time, but it took hard work and convincing, our multidisciplinary team, our exec. We literally had to present to our exec for that, but we had to go through that, writing reports, getting the data, analyzing all of that. So there is some effort that needs to be put in, but if you put the right effort in and get the right people on board, we can, adopt technology earlier. And like David was saying, if we wait till, NHS England say, do this and then adopt it, it's going to take forever. But locally, we could actually do things and then share like we are doing now. And other people saying, oh, what have you done? Can we learn? For instance, Oxford now, who is close to us, they are sending their trainee, the doctors to come to see what we are doing in terms of the virtual world and how we're using BioFire to transform our, service, our sepsis service. Also, NHS EI, they are coming as well and, seeing what we are doing. So I think it probably works that way, bottom up, than top down, when people think, oh, somebody has made a decision up there that we have to implement this. Of course, we have to do that sometimes, but sometimes when we do it and then they see and then we share amongst ourselves, I think you tend to get buy-in better that way. So, and that's the end of our presentation. Do you have any questions?